morning, all of you. Myself, Dr. Pradeep Kumar Bansal, Assistant Professor in Cardiology Department at UNMICRC Institute of Cardiology and Research Center, Ahmedabad. Today, we will discuss about perioperative cardiovascular assessment and management of patient undergoing non-cardiac surgery. And this topic I have adapted from the 2024 AHA and ACC guideline for perioperative cardiovascular management for non-cardiac surgery. So today's discussion outlines are epidemiology of cardiovascular disease in patients undergoing non-cardiac surgery, how to assessment of the perioperative risk, and preoperative cardiovascular diagnostic testing, how to stepwise approach to perioperative cardiac assessment in non-cardiac surgery, how to manage individual cardiovascular disease perioperatively, and how to manage perioperative medical therapy management, and management of perioperative and STEMI, and consideration for the special population like patient undergoing kidney or liver transplantation, and take-home message. So first, epidemiology of cardiovascular disease in patient undergoing non-cardiac surgery. In a recent report from the USA National Inpatient Sample Database, nearly half of adults aged more than 45 years undergoing major non-cardiac surgery presented with at least two cardiovascular risk factors, in which 18% had coronary artery disease, 4.7% had a risk of stroke, 7.7% had a modified revised cardiac risk index of score more than 3. And in a large registry including 37,000 consecutive patients undergoing PCI with deaths, the rate of non-cardiac surgery after PCI were 11% and 24% at 1 and 3 years respectively. So first we discuss about how to assess the risk in patient undergoing non-cardiac surgery, in which two factors are there: surgical risk and the patient risk. In surgical risk, first we define the urgency of the surgery, in which there is a 4 category according to risk of the surgery. First is the emergency surgery, in which there is a threat to life or limb without surgical intervention within 2 hours. So surgery should be done within 2 hours. In urgent, surgery should be done within 2 to 24 hours. And in time sensitive surgery, the surgery may delay up to 3 months to complete evaluation and then manage. In elective surgery, there should be complete evaluation before surgery. And type of surgery, there is a low risk or elevated risk. Low risk surgery like breast surgery, gynec surgery, and obstetric surgery. Intermediate risk surgery like ENT, genitourinary, orthopedic surgery, and general surgery. And high risk surgery are like vascular surgery, thoracic surgery, transplantation surgery, and neurosurgery. In overall risk, that include both patient risk and the surgical risk. So if there is a MACE less than 1%, it is considered as a low risk surgery. If there is MACE more than 1%, then it considered as elevated risk surgery. So there should be a team-based care for preoperative management of patient undergoing non-cardiac surgery, in which including surgeon, nurse, cardiologist, primary care physician. So there should be team-based perioperative care. So if there is a interdisciplinary models and some pathways, and which standardize perioperative practices and which accelerate and coordinate recovery. And there should be a telemedicine visit, preoperative and postoperative, which improve the decrease the case cancellation, decrease healthcare utilization, and decrease the readmission. So overall, improve the patient satisfaction. So risk prediction, there should be multiple things in this. First is there are some risk calculator for assessment of risk, surgical factors like surgical timing and risk, patient factors like medical condition of the patient, functional status of the patient, and in cardiac biomarkers. Cardiac biomarkers is only indicated in patient already have cardiovascular disease, or if age more than 65 or age more than 45 with symptoms suggestive of cardiovascular disease. So for recommendation in patient with known cardiovascular disease being considered for non-cardiac surgery, a validated risk prediction tool can be useful to estimate the risk of perioperative MACE. So there are some risk calculators like Goldman Index of Cardiac Risk, Revised Cardiac Risk Index, and multiple other risk calculators are also, but more commonly we use Revised Cardiac Risk Index. So in Revised Cardiac Risk Index, it is a tool that estimates the 30-day risk of cardiac arrest, MI, and death after the surgery. And the RCRI is used to assess the risk of MACE event. So it includes a 6 point. First is the ischemic heart disease. It may be history of myocardial infarction, positive exercise test, current complaint of ischemic chest pain, or use of nitrate therapy or ECG suggestive of QA. History of heart failure, history of CVA, and history of diabetes which need insulin therapy, history of renal dysfunction, that serum creatinine more than 2, and any high risk type of surgery like major vascular surgery, neurosurgery, all this. So according to present of the risk of this 6 factor, there will be percentage of the cardiovascular complication and cardiovascular death. The next is the patient factors. In patient factors, 2 things should be considered, like function capacity of patient and frailty. So in function capacity, in patient undergoing elevated risk NCS, structural assessment of functional capacity is reasonable to stratify risk of perioperative adverse cardiovascular event. So in easily we can assess the functional capacity, like if we ask the patient if he is able to walk up to 2 flights of stairs, it may conclude that the patient MET should be more than 4. And other scale are also like Duke Activity Status Index. For frailty, in all patients with perceived frailty who are undergoing elevated risk NCS, preoperative frailty assessment using a validated tool can be useful for evaluating perioperative risk and guiding management. So why we should consider this frailty? Physiological declines across multiple organ systems resulting in increased vulnerability to stress. Prevalence of 10% among community dwelling individual more than 65 years of age, and frailty is 2 times higher in women than the men. And there is a multiple scale for calculated the frailty. And next thing is the preoperative risk stratification. The biomarkers are also included in this stratification, but these biomarkers have some recommendation, like in patient with known CVD, age more than 65 or age more than 45 with symptoms suggestive of cardiovascular disease, then only there is a BNP before surgery to supplement the evaluation of perioperative risk. That is a class 2A indication. And for cardiac troponin, the in patient with known history of cardiovascular disease, age more than 65 and age more than 45 with symptoms suggestive of cardiovascular disease, then it may be reasonable to measure cardiac troponin before surgery to supplement evaluation of the perioperative risk. That is a class 2B indication. Next thing is some test should be done before the some diagnostic testing should be done before the non-cardiac surgery to evaluate the risk. So first is if there is elevated risk, intermediate or high risk surgery, then if there is a low risk surgery, there is a ECG, it may be no any benefit. But if there is a high risk surgery and if patient has a known cardiovascular disease, arrhythmia, peripheral arterial disease, CVST, then it should be obtained the 12-lead ECG. And if preoperative ECG shows new abnormalities like ST segment elevation, depression, LVH, significant Q waves, high degree AV block, bundle branch block, it should be obtained further evaluation to refine the cardiovascular risk. Next is the indication and assessing the ventricular function in patient with undergoing NCS. For RV function, RV dysfunction associated with adverse cardiovascular outcome in NCS, routine perioperative evaluation RV function is not recommended in asymptomatic and clinically stable patient. But for LV function, if their patient have the new dyspnea, physical examination showing heart symptom of heart failure and suspected or new worsening LV dysfunction is there, then there is a known case of heart failure, then preoperative assessment of LV function is reasonable at 2 indication. And if there is a no history of heart failure but patient have symptoms suggestive of dyspnea and suspicion of LV dysfunction, then should be preoperative assessment of LV function is recommended. Next diagnostic testing is like stress test and CPET. For stress test, if patient undergoing surgery have low risk of cardiovascular, like less than 1% of miss according to the risk calculator, and procedure also is low risk, and patient have function capacity of more than 4 minutes, then there is no recommendation of a stress test. But patient have poor or unknown function status like less than 4 minutes, undergoing elevated risk non-cardiac surgery, and elevated risk perioperative risk or that is a more than 1% of miss, then stress test should be considered, that is the class 2B indication. For CPET, can provide additional physiology data to inform perioperative care or guide optimization in patients with reduced functional capacity undergoing elevated risk procedure. And there is a multiple modality of stress tests like vasodilator, pharmacology stress imaging, exercise stress testing, and dobutamine stress echocardiography. And next testing is the coronary CT angiography. So coronary CT angiography is how it indicated. In patient risk is low, surgical risk also low, and functional capacity is good, then there is a no recommendation of CT coronary angiography. But if patient have high risk, surgical risk is also high, and functional capacity is unknown or less than 4 minutes, then there is a class 2B indication of CT coronary angiography. Next is invasive coronary angiography. So, in patient undergoing NCS, routine preoperative invasive coronary angiography is not recommended to improve perioperative outcomes. So, but some condition like preoperative angiography remains indicated for ACS patient, angina despite maximal medical therapy, and moderate to severe ischemia or obstructive left main disease. Then coronary angiography is indicated. So, next and important discussion in this today's topic is how to stepwise approach to preoperative cardiac assessment in non-cardiac surgery. First, whenever there is a patient come for cardiological reference for the clearance was cardiology side, first we should have the history of the patient of any cardiovascular risk factor, disease or symptom. If there is no any like this risk factor or disease symptom, then we should proceed to the surgery. For cardiovascular risk factors like hypertension, smoking, dyslipidemia, diabetes, women more than 65 years, men more than 55, obesity, and family history of premature CAD. If this cardiovascular risk factor are not there in patient and there is no any symptom, then we should proceed to surgery. Next, if any of the cardiovascular risk factor is present, but surgery is an emergency surgery that surgery should be needed within the 2 hours, then we should not evaluate further and proceed with surgery. If surgery is not emergency surgery, then we should ask the patient, we should assess the patient of is there any condition like ACS, unstable cardiac arrhythmia, and decompensated heart failure. If any of this is present, we should evaluate and manage this condition before undergoing surgery. If this condition is not there, when we should after that we should calculate the preoperative risk estimation according to multiple risk factor calculator and other factor risk modifier. If any of the risk modifiers are present like severe valvular heart disease, severe pulmonary hypertension, elevated risk congenital heart disease, prior coronary stent CABG, and history of recent stroke or any CID like pacemaker ICD is present, then we should evaluate further. So, then we further evaluate this patient like perioperative risk estimation. If there is a low risk or if there is a no risk modifier, then we should proceed to the surgery. Next, if there is elevated risk but there is a no risk modifier, then we should consider other investigation like ECG and another stress test. If there is a poor or unknown functional capacity, then we should yes, then we should proceed to the other decision making further evaluation. If there is a no any of risk factor or there is a good functional capacity or if there is no any condition like abnormality in ECG, then we should go further, we should proceed to surgery. But if there is a risk modifier is present and there is any calculated risk, we should consider appropriate team based consideration for NCS timing and perioperative diagnostic testing and management. And we further evaluate the patient with ECG, echocardiography and other testing. So, if after the multiple diagnostic testing, if we further testing impact decision making of preoperative care, if there is a no, then we should proceed to surgery or consider alternative strategy. If there is any testing which suggestive that we should proceed further or we need or more investigation, then we can consider preoperative biomarker assessment like BNP and troponin. If there is a normal, then we should go proceed to surgery. If abnormal, we should multidisciplinary team discussion about the risk and benefit of the further cardiac evaluation. If there is a low risk, then we can again consider the surgery. But if there is a high risk, then we consider alternative strategy or proceed to surgery according to the team-based discussion. Next is the how to preoperative management of individual diseases. First, we discuss about the coronary revascularization. In patient undergoing non-cardiac surgery, according to some study, there is 18% of patient undergoing non-cardiac surgery have coronary artery disease. And if there is a patient has a history of myocardial infarction, there is a 3.5% risk more chances of increased risk of perioperative MACE. And if patient have prior coronary stent within 2 years, there is a 2 times higher increased risk of perioperative MACE. So, what is the indication of revascularization prior to elective NCS? First, for patient with any ACS, preoperative revascularization is recommended. Then, for patient with chronic coronary disease and significant left main stenosis of more than 50%, consider preoperative revascularization, that is a 2 indication. But for patient with non-left main CAD, revascularization is not recommended prior to the elective NCS. Next is the how to manage the hypertension preoperatively and perioperatively. So, patient undergoing non-cardiac surgery, 25% of patient have the hypertension. So, in most patients with hypertension, it is reasonable to continue medical therapy for hypertension throughout the perioperative period. In most patients undergoing elective elevated risk surgery who have cardiovascular risk factor and recent history of raised blood pressure, like consider deferring surgery. And for intraoperative management in patient undergoing NCS, maintaining intraoperative mean arterial pressure around 60 to 65 and systolic blood pressure of more than 90 is recommended. For postoperative management in patient undergoing NCS, treatment of hypotension, mean arterial pressure less than 60 in the postoperative is recommended. And in patient with hypertension undergoing NCS, it is recommended that preoperative antihypertension medication be restarted as soon as clinically reasonable. Next is the perioperative management of heart failure patient. If there is heart failure with elective non-cardiac surgery, hold the SGLT2 inhibitor 3 to 4 days prior to surgery. If there is a compensated heart failure undergoing non-cardiac surgery, reasonable to continue GDMT excluding SGLT2 inhibitor. And if there is advanced heart failure who are clinically decompensated, postpone elective surgery and obtain cardiology consultation. Next is the perioperative management of hypertrophic cardiomyopathy. So, management consideration is continue beta blocker and non-dihydropyridine calcium channel blocker without interruption, avoid hypovolemia and reduce preload, avoid hypotension and reduce afterload. So, recommendation is in patient undergoing NCS, factors that aggravate or trigger dynamic outflow obstruction are harmful and should be avoided to reduce the risk of hemodynamic instability. And if hypotension is yellow, prioritize intra-IV fluid administration, use alpha agonist instead of beta agonist. Consider intraoperative echocardiography to evaluate LVOT obstruction, and beta blockade may be necessary to reduce the LV myocardial contractility and relieve LVOT obstruction. And next is the perioperative management of pulmonary hypertension. In patient receiving a stable dose of targeted medical therapies for pulmonary arterial hypertension undergoing NCS, it is recommended to continue these agents to reduce the risk of development of perioperative MACE. In patient with severe pulmonary hypertension undergoing elevated risk NCS, referral to consultation with specialized pulmonary arterial hypertension center to support risk assessment and optimization of perioperative management. In patient with severe PH undergoing elevated risk NCS, invasive hemodynamic monitoring is reasonable to guide intraoperative and postoperative care. In patient with precapillary pulmonary hypertension undergoing elevated NCS, perioperative administration of short-acting inhaled pulmonary vasodilator may be reasonable to reduce the elevated RV afterload and prevent acute decompensated right heart failure. Next is the perioperative management of adult congenital heart disease. In patients with intermediate to elevated risk congenital heart disease lesion, preoperative consultation with adult CSD especially is recommended. So, this congenital heart disease is divided into low risk, intermediate risk, and high risk according to anatomy and functional and hemodynamic status. Like in low risk congenital heart disease included patient with isolated small congenital heart disease, in patient with repaired lesion with no residual shunt, in patient with bicuspid aortic valve disease. But patient in low risk functional and hemodynamic stress considered as a NYHA class 1, no chamber enlargement, no residual shunt, no pH, and no arrhythmias is considered as a low risk. Then is the according to anatomy wise, if there is unrepaired moderate to large shunt, repaired CSD with moderate to large residual shunt, obstructive left and right sided lesion, abstinent anomalies anomalous coronary artery arising from pulmonary artery, anomalous aortic origin of a coronary artery from the opposite sinus is considered as a intermediate risk. And in this lesion, if patient is NYHA class 2 to 4, limited access capacity, presence of residual shunt, pH, cardiac chamber enlargement, significant valvular dysfunction, presence of heart failure, then is also considered as an intermediate risk. In high risk adult congenital heart disease, a lesion like single ventricle patients, unrepaired palliative cyanotic congenital heart disease, DURV, pulmonary atresia, truncus, TGA, interrupted aortic arch with NYHA class 2 to 4, limited access capacity, significant valvular dysfunction, arrhythmia, pH, and heart failure, they are all included in the high risk category. Next, we discuss about the valvular heart disease and non-cardiac surgery. First, we discuss about the aortic stenosis. So, what is the recommendation? Recommendation is in patient with severe aortic stenosis should be evaluated for the need of aortic valve intervention prior to elective NCS to reduce the perioperative risk. In patient with suspected moderate or severe AS who are undergoing elevated risk NCS, preoperative echocardiography is recommended. In asymptomatic patient with moderate to severe AS and normal LV systolic function assessed by echocardiography, it is reasonable to proceed with elective low risk NCS. So, if patient has severe aortic stenosis requiring elective or time sensitive NCS, there is a multi-team discussion like cardiology, anesthesia, and surgery. So, first we consider is their patient is symptomatic or asymptomatic. If symptomatic with severe AS and it is candidate for aortic replacement, then we should proceed to the for evaluate for AVR before elective NCS. Then team-based discussion about the TAVI or SAVR. But if patient is not candidate for AVR, then consider non-surgical management, minimally invasive alternative, BAV prior to NCS or palliative care, or proceed with elevated risk surgery after shared decision making. But if patient have severe aortic stenosis with asymptomatic, then we should evaluate for LV function. If there is a LV function is less than 50%, then we consider for AVR. But if there is LVF is more than 50% with severe AS with asymptomatic, if there is a elevated risk surgery, then we can delay non-cardiac surgery. Then if there is elevated risk surgery, or so we plan to can delay the non-cardiac surgery, then we go to AVR. But if we cannot delay the non-cardiac surgery, then also there is a team-based discussion regarding how to proceed. But there is a severe AS with asymptomatic with ejection fraction more than 50%, there is a so there is low risk surgery, then reasonable to proceed with elective low risk non-cardiac surgery. Next is the mitral stenosis, and so in patient with severe MS should be evaluated for the need for mitral valve intervention prior to elective NCS. It is a class 1 indication. In patient with severe MS who cannot undergo mitral valve intervention prior to NCS, perioperative invasive hemodynamic monitoring is reasonable. In patient with severe MS who cannot undergo mitral valve intervention prior to NCS, perioperative heart rate control may be considered to prolong diastolic filling time and decrease perioperative cardiovascular complication. Next is the valvular regurgitation, like mitral and aortic regurgitation. In patient with suspected moderate to severe valvular regurgitation, perioperative echocardiography is recommended. Patient with valvular heart disease who meet indication for valvular intervention based on clinical presentation and severity of regurgitation, the need for valvular intervention should be considered before elective elevated risk NCS. In asymptomatic patient with severe MR, normal LV function, estimated PS systolic pressure less than 50, it is reasonable to perform elective NCS. In asymptomatic patient with moderate to severe AR and normal LV function, it is reasonable to perform elective NCS. Next is the valvular heart disease with patient with undergoing TAVI or TEER. For TAVI, for patient undergo TAVI, it is reasonable to perform NCS early after successful TAVI as clinically indicated. For patient who undergo mitral valve TEER repair, it is reasonable to perform NCS after successful mitral valve intervention as clinically indicated. Next is the patient with atrial fibrillation and undergoing for non-cardiac surgery. So, perioperatively in patient with new onset atrial fibrillation identified in the setting of NCS, initiation of post-operative anticoagulation therapy can be beneficial after considering the competing risks associated with thromboembolism and perioperative bleeding. In patient with rapid atrial fibrillation identified in the setting of NCS, it is reasonable to treat potential underlying triggers contributing to AF and rapid ventricular response. Post-discharge in patient with new onset atrial fibrillation identified in the setting of NCS, outpatient follow-up for thromboembolic risk stratification and AF surveillance are recommended, giving a high risk of AF recurrence. Next, an important thing comes is the cardiovascular implanted electronic devices with patient undergoing NCS. So, in patient with CIDs having elective non-cardiac surgery, should have a management plan developed before surgery if electromagnetic interference like use of cautery is anticipated, including identification of the type of CID, manufacturer and model. So, it is important because model and manufacturer is important because to interrogate and adjust the setting of the device. Patients who are pacemaker dependent having surgeries above umbilicus with anticipated electromagnetic interference should have a pacemaker reprogram or place magnet on the generator to provide an asynchronous mode to avoid pacing inhibition. Next is pacemaker dependent patient with the transvenous ICD undergoing surgery above umbilicus with anticipated EMI should have the device reprogrammed, and if not pacemaker dependent, then either reprogram or magnet placed on the generator can be used to inhibit the tachytherapy or inappropriate shock. So, in patient with ICD, if the ICD that are the pacemaker dependent, we go to asynchronous mode only, and with ICD with not pacemaker dependent, we inhibit the tachytherapy only. Next is a patient who have pacemaker or ICD reprogrammed to asynchronous pacing or having a tachytherapy program of before surgery should have device functioning restored in the post-operative setting before to hospital discharge. So, recommendation is for leadless pacemaker who are pacemaker dependent having surgery with anticipated electromagnetic interference above umbilicus should have their pacemaker reprogrammed to an asynchronous mode. For patient with subcutaneous ICD having non-cardiac or non-thoracic surgery with anticipated AMI above groin, it is reasonable to reprogram the device or use a magnet to temporarily disable tachytherapy. Next, patient have history of previous stroke or TIA and planned for elective NCS. So, recommendation is if the patient history of stroke or TIA reasonable to delay the elective NCS for at least 3 months after the most recent event to reduce the incidence of recurrent stroke and MACE. In patient for obstructive sleep apnea, in patient scheduled for NCS, screening for OSA using validated questionnaire is reasonable to assess the risk of perioperative complication. So next is how to manage the patient perioperative which are on some cardiac medical therapy like statins, RAS inhibitors and alpha-2 agonists. For statins, in patient scheduled for NCS, continue statins in those already on one to reduce MACE risk, and in statin naive patient who meet criteria and scheduled for NCS, recommended initiation of statin perioperative with the intention to for long term use according to ASCVD risk score. For RAS inhibitor, in patient with controlled blood pressure undergoing elevated risk NCS, chronic RAS inhibitor holding 24 hours prior to surgery may be beneficial to limit the intraoperative hypertension. In patient chronic RAS inhibitor for HFrEF, reasonable to continue perioperative. So, patient on RAS inhibitor for hypertension, stop RAS inhibitor before 24 hours. In patient for RAS for heart failure, continue the RAS inhibitor. For alpha-2 agonist, initiation of low dose chlorine perioperative is not recommended to reduce the cardiovascular risk in patient undergoing NCS. Next is a patient on antiplatelet therapy and timing of NCS in patient with coronary artery disease. So, for antiplatelet therapy in patient with CAD undergoing elective NCS, perioperative management of antiplatelet therapy and timing of surgery should be determined by multidisciplinary team with shared decision making to weigh the risk of bleeding, thrombosis and consequences of delayed surgery. So, how to perioperative antiplatelet management post PCI? So, in patient with prior PCI undergoing NCS, it is recommended to continue low dose aspirin which is 75 to 100 milligram if possible to reduce the risk of cardiac event. In patient with CAD who require time sensitive NCS within 30 days of PCI with BMS or less than 3 months of PCI with DES, DAPT should be continued unless the risk of bleeding outweigh the benefit of prevention of stent thrombosis. So, with elective NCS more than 3 months, we consider a single antiplatelet. If less than 3 months, we should consider DAPT. And in patient with prior PCI in whom the oral anticoagulant monotherapy must be discontinued prior to NCS, aspirin should be substituted when feasible in the perioperative period. And in selective patients after PCI who have high thrombotic risk, perioperative bridging with IV antiplatelet therapy may be considered less than 6 months after DES or less than 30 days after BMS. Like patient undergoing LM-plasty, high thrombotic risk patient. So, intraoperative bridging with IV antiplatelet therapy. And perioperative antiplatelet management patient without prior PCI. In patient with chronic coronary disease without prior PCI undergoing elective NCS, it may be reasonable to continue aspirin in a selected patient. In patient with CAD but without prior PCI undergoing elective NCS, non-carotid surgery, routine aspirin is not beneficial. So, it is the antiplatelet therapy and timing for NCS in patient with CAD. So, timing of non-cardiac surgery after PCI, first is the optimal timing for elective time sensitive NCS for prior PCI requiring management of DAPT. So, first if patient is undergoing only balloon angioplasty only, there is no coronary stent placed, delay NCS up till minimum 14 days. If there is a patient with bare metal stent PCI, delay non-cardiac surgery minimum more than 30 days. If there is history of DES PCI, there is two conditions for DES, like for patient undergoing DES for ACS, next is the patient undergo DES PCI for chronic coronary disease. If patient undergo DES PCI for ACS, delay non-cardiac surgery for minimum 12 months after the DES PCI and delay NCS for more than 3 months after DES PCI time sensitive indication for surgery is needed. So, minimum 3 months or for class 1 indication is for 12 months. If DES PCI is less than 1 month, do not perform surgery. So, minimum if within 1 month should not be performed any elective non-cardiac surgery after DES PCI. For chronic coronary disease, delay NCS for minimum 6 months after the DES PCI, and if there is a time sensitive surgery, minimum delay for 3 months and should not perform any non-cardiac surgery before 1 month. And next is the how to manage the oral anticoagulant perioperatively. In patient with cardiovascular disease receiving oral anticoagulant who require elective NCS, multidisciplinary team-based approach to duration of interruption is recommended to balance risk of thromboembolism and bleeding. For oral anticoagulant breathing, in patient with cardiovascular disease and high thrombotic risk undergoing NCS where interruption of vitamin K antagonist is required, preoperative breathing with parenteral heparin can be effective for thromboembolic risk reduction. In most patients with CVD who are planned for an elective NCS where OSA interruption is warranted, routine breathing is not recommended. And for oral anticoagulant reception in patients with preoperative OSA interruption, resumption of OSA is reasonable after hemostasis is achieved. For beta blocker, in patient on stable beta blocker dose undergoing NCS, beta blocker should be continued. And for in patient with planned elective NCS with a new indication of beta blocker may be initiated in advance before surgery before 7 days. In patient with NCS who have no immediate beta blocker need, beta blocker should be not be initiated. For patient having diabetes, in patient with or at risk diabetes who are scheduled for elective NCS, preoperative HbA1c testing reasonable if not performed within 3 months. In patients scheduled for NCS, SGLT2 inhibitors should be discontinued 3 to 4 days before surgery. In patient with diabetes or impaired glucose tolerance, continuation of metformin during the periodic period is reasonable to maintain the glycemic control. So, for choice of anesthetic agent technique, so there is a for patient undergoing NCS use of volatile based anesthetic or total IV anesthesia is reasonable. In patient undergoing anesthesia when neuroaxial anesthesia is available, either neuroaxial or general anesthesia is reasonable. But for multiple study, there is no apparent difference in cardiovascular events such as myocardial injury or infarction with any of the agent. Perioperative pain management, epidural analgesia. For recommendation is post-operative patient undergoing major abdominal surgery, and for preoperative in patient with hip fracture. Preferred site is lumbar, may be considered to reduce perioperative cardiac event. Intraoperative monitoring technique for patient undergoing non-cardiac surgery with high risk. So, for like echo and pulmonary artery catheterization, body temperature. So, it is recommended only with patient with high risk surgery with high cardiovascular risk factors. Perioperative anemia management. Perioperative anemia and bleeding are modifiable risk factor for post-operative morbidity and mortality. So, patient undergoing NCS with expected blood loss trending as it is reasonable to reduce the intraoperative blood loss, blood transfusion and incident anemia. And there is a new term is like myocardial injury after the non-cardiac surgery. So, how to surveillance this myocardial injury? May be reasonable to measure troponin 24 to 40 hours after the elevated risk NCS if there is a known CVD, symptom of CVD, age more than 65. Routine perioperative cardiac screening is not recommended in low risk NCS without signs and surgery of MI. So, what is the diagnosis? If cardiac troponin is more than 99% of upper range of limit with rise and fall pattern, presumed ischemic origin, 12-lead ECG without ST elevation and no evidence of MI. So, how to manage? Outpatient follow-up is reasonable for further evaluation and optimization of cardiovascular risk factor. Antithrombotic therapy may be considered to reduce cardiovascular events. Next is how to manage the patient with perioperative NSTEMI and STEMI. Acute myocardial injury or other evidence of possible MI. If there is a history, physical examination and 12-lead ECG, if there is a ST segment elevation, so then manage according to ACA or AHA guideline of STEMI, including the invasive coronary angiography. If there is a non-ST elevation MI, if there is a fit into criteria of any of the more than one criteria for MI, then it may be non-STEMI. So, may further investigated and managed according to a guideline. If there is a not fit into any criteria of MI and post-operative, it may consider as a post-operative myocardial injury only. It may be ischemic or it may be non-ischemic. If there is a non-ischemic, then there is only the myocardial injury that consider and manage accordingly. If there is a non-ischemic myocardial injury, treat as the underlying cause. And last is the consideration for a special population like patient undergoing kidney and liver transplantation. Both of the surgery is the very high risk surgery. So patient planned for kidney transplant candidate without any known factor of coronary heart disease. If there is any symptomatic cardiac disease, then cardiology refer management of according to guideline. If there is no any symptom of cardiac disease, obtain transthoracic echo and 12-lead ECG. If there is significant known CSG finding, significant valve disease, pulmonary hypertension is there, then manage accordingly. And if there is a high suggestive of coronary heart disease, EF less than 40% and regional valve motion abnormality, then we should consider the other investigation like coronary angiography, dobutamine stress echo. And if there is a meet or any of the low risk criteria for coronary heart disease like age less than 60, non-CKD factors, duration of dialysis, prior kidney transplant less than 5 years, and no evidence of silent MI or ECG, then the functional assessment of stress echocardiography or anatomic assessment. If high risk anatomy and moderate to large ischemia, then we should consider invasive management. If there is normal or small ischemia, no further cardiac testing is required. And kidney transplant candidate with a known coronary heart disease, if there is symptomatic, consider for further investigation. If there is a coronary angiogram in the past 1 to 2 years, so we consider is there obstructive CSD, yes, then revascularization either PCI or CABG, and if all of the following like more than 3 to 6 months of GDMT, and if needed revascularization, no cardiac symptom in EF more than 40%, then no further testing. And but GDMT failed to be adequate, does not warrant a revascularization, then cardiology and transplant team to discuss the kidney transplant candidacy and further management on case to case basis. But there is a no active cardiac symptom or less than for EF less than 40%, coronary angiography for further risk stratification, GDMT if EF less than 40% despite CSD treatment, consider referral to heart failure specialist and transplant candidacy on a case to case basis. But in there is in ischemic CKD trial, an invasive strategy in kidney transplant candidate did not improve outcome compared with conservative management. Data do not support routine coronary angiography or revascularization in patients with advanced CKD and chronic coronary syndrome listed for transplant. For liver transplant, for if liver transplant candidate for there is a known coronary heart disease, then yes, coronary angiography within 1 year, no, then cardiology refer for TE, 12-lead ECG and coronary angiography or CT coronary angiography. If there is a known coronary heart disease, no. If there is any symptom, then consider for cardiology referral. And if there is no symptom of CSD, then consider for ECG and echo. And if there is a significant finding of any valvular heart disease, pulmonary hypertension, then consider for cardiology referral and further management. And any feature which highly suggestive of CSD, then we consider for CT coronary angiography or coronary angiography. Or any CSG risk factor is there, we consider for more than 2 of the coronary heart disease risk factor or diabetes or NAS, then is all these factors are not present, then we consider for stress echocardiography. And if any of the risk factors present, age more than 40 or unstable more than 4 minutes, then we consider for stress echography. And if they are unable to perform any stress echography, then we consider there is no need for further stress testing. So coronary angiography in liver transplant candidates, if there is non-obstructive CAD, GDMT only. Hemodynamically significant stenosis in major cardiac artery serving significant territory and amenable to PCI, and mailed score less than 30, then deaths with minimum 3 months DAPT, mailed more than 30, deaths and consider for 1 month DAPT. complex left main or three vessel disease considered for combined CABG and liver transplant or hybrid approach. Unrevascular COD with evidence of significant risk myocardium decline for liver transplant. So, finally, take home message for today discussion. So, there is a stepwise approach to perioperative cardiac assessment assists clinician in determining when surgery should proceed or when a pause for further evaluation is warranted. Cardiovascular screening and treatment of patients undergoing non-cardiac surgery should adhere to the same indication as non-surgical patient. Stress testing should be performed judiciously in patients undergoing non-cardiac surgery, especially those at lower risk, and only in patients in whom testing would be appropriate independent of planned surgery. New therapies for management diabetes, heart failure and obesity have significant perioperative implications. SGLT2 inhibitors should be discontinued 3 to 4 days before surgery to minimize the risk of perioperative ketoacidosis associated with their use. Team-based care should be emphasized when managing patients with complex anatomy or unstable cardiovascular disease. Myocardial injury after non-cardiac surgery is a newly identified disease process that should not be ignored because it portends real consequences for affected patients. Patients with newly diagnosed atrial fibrillation identified during or after non-cardiac surgery have an increased risk of stroke. These patients should be followed closely after surgery to treat reversible cause of arrhythmia and to assess the need for rhythm control and long-term anticoagulation. Perioperative raising of oral anticoagulant therapy should be used selectively only in those patients at higher risk for thrombotic complication and is not recommended in the majority of cases. Thank you.